Hi, everyone. Today we're going to be continuing our in-depth unit of cranial anatomy, but this microlecture is actually going to be focusing on cranial nerve anatomical relationships as they leave the brain case and how they can be used to help explain patient presentations in a clinical setting. Now, this is simply a list of learning resources that helped me as I was building this lecture. They are here for you to take or leave. But by the end of this microlecture, you should be able to broadly recall the function of each cranial nerve. I'm going to be going over it in a kind of a broad sense. I know that we've gone through it more specifically in the past. Today is a broader look at it, so I can fit it within the time. Trace the route of each cranial nerve from the brain to its target structures, annotating cranial foramina and close relationships with other neurovascular structures. And then, based on the functional and anatomical relationships of each cranial nerve, consider the consequences, i.e. patient presentation and potential causes of dysfunction. This third one is going to be more heavily pursued in person, but we are going to touch on it today. Here's the general outline of the lecture. And I've included this broken down into chapters for your convenience. So let's actually start talking about cranial nerve anatomy by using a clinical example. So a 30-year-old woman presents with an 11-year history of chronic occipital headaches. She reports increasing concern because over the last year, she's had worsening difficulty speaking and swallowing. And recently, she's noticed that it's difficult for her to turn her head. Your examination reveals that she does have a right deviated uvula. So based on her presentation, we should really try to answer the following questions, which is, which cranial nerves are experiencing dysfunction? Are there any locations shared by all of these nerves that could explain a singular lesion producing all of the presentation? And what are potential sources of a lesion to cause the patient presentation? Now, if you'd like, you can actually pause the video right now and try and answer the question to assess your own knowledge base walking into this lecture. If not, we will move on. Okay, so we're going to be discussing cranial nerves. We're going to be thinking about them from the point of view of the skull. Specifically, we're going to be viewing it from the cranial base, which is the portion of the skull upon which the brain rests. And it's made up of, in part, the sphenoid bone, the temporal bone, and the occipital bone. This isn't a great view to see everything we're going to see, though. It's just very easy to visualize it. Now, what we're going to do is we're actually going to flip the skull over, look at it from above, from the superior aspect. We can identify three cranial fossa: the anterior cranial fossa, upon which sits the frontal lobes and the olfactory tracts and bulbs; the middle cranial fossa, which is made up of the temporal and sphenoidal bones, and it cradles the temporal lobes, pituitary gland, and cranial nerves 3 through 8. And last but not least, the posterior cranial fossa, which houses the brainstem, cerebellum, and cranial nerves 9 through 12. So the cranial base is really difficult because it contains the vast majority of the foramina in the crania. And anytime that there's a foramen, it can be blocked and cause pathologies, but these pathologies are easy to understand if you know what's passing through the foramen. Now, this is kind of a chopped down lecture because we're actually only looking at the foramen, each of the foramina that have cranial nerves passing through them. So it's an abbreviated list versus everything there. Now, an important thing to consider before we get into the antero-posterior march through the cranial nerve foramina is that the dura are anchored within the foramina. So the meninges, the dura of the meninges, actually attach into the foramina partially. There's not like a giant space between the connective tissue of the brain and the foramina. They actually are connected. So if there is a problem with the dura, it can affect the foramina very quickly. Just a thought. So let's start off by taking a look at the anterior cranial fossa. And at the anterior end of the anterior cranial fossa, we have the cribriform foramina, also called the cribriform plate. This is the ethmoidal bone structure through which olfactory bulbs drops olfactory nerves to innervate the nasal olfactory mucosa to give us our special sense of smell. Posterior to that, on the lesser wing of the sphenoid, you have the optic canal. This is the tube through which the optic nerve and the ophthalmic artery travel to then supply our special sense of vision via innervation of the retina, and basically the entire blood supply of the eye and orbit via a bunch of split off arteries as it comes in. And while they travel through the optic canal here, as they emerge, this structure we're looking into the orbit is called the optic foramen. So that's it for the anterior cranial fossa. Now let's take a look at the middle cranial fossa. Things get a bit more complicated here. So the anteriormost structure is called the superior optic fissure. It lays infralaterally to the optic canal and has four nerves running through it, three of which directly relate to the eye, and another one that has partial relation to it, but we'll see a little bit more. So those four nerves are cranial nerves 3, which is the oculomotor nerve, 4, the trochlear nerve, 6, the abducens nerve. So all of the muscular innervation of the orbit, as well as the intrinsic musculature of the eye, is present in these three nerves coming through the superior orbital fissure. Additionally, you have the ophthalmic division of the trigeminal nerve. This is a sensory portion that innervates the ophthalmic region of the face and head, including a large list of structures. It's purely sensory, though. Now, posterior to your superior optic fissure, you have the foramen rotundum, which is a relatively round foramen. Through here, the maxillary division of the trigeminal nerve runs. This is another purely sensory division, and it runs through and then goes out to innervate the midface and a ton of internal structures, including things like the hard palate, the upper teeth, the gums, things of that nature, as well as portions of the skin. We have one more trigeminal division, the mandibular division, and this actually goes through the foramen ovale. So we have the foramen ovale posterior to the foramen rotundum. Through the foramen ovale, we have the mandibular division and a nerve called the lesser petrosal nerve. This is actually a portion of the glossopharyngeal nerve that branches off before the rest of the glossopharyngeal nerve goes through the jugular foramen. And the lesser petrosal nerve provides the parasympathetic motor innervation for the parotid gland. And the way that this works is it basically just hitches a ride. It travels through the temporal bone and then hooks up with the mandibular nerve. They don't become the same structure. They're just running side by side, and you can actually see this pulled apart in specimens. The posterior most middle cranial fossa foramen that we're going to discuss is the internal acoustic meatus. The internal acoustic meatus actually has two nerves running through it. Cranial nerve 7, which is the facial nerve, which provides motor control over the muscles of facial expression, as well as motor innervation to the middle ear muscles, and the special sense of taste to the anterior 2/3 of the tongue. There's also cranial nerve 8, which enters the internal acoustic meatus and then goes straight to the vestibular cochlear complex to provide the special senses of balance and hearing. Now that we've finished up the first two cranial fossa, we're moving to the posterior cranial fossa, which has two main foramina we're going to talk about. We're not going to talk about the foramen magnum because that's the brainstem and spinal cord exiting. So the first foramen we're going to talk about is the jugular foramen. The jugular foramen is unique because it has 3 cranial nerves exiting, 2 of which have a lot of ground that they cover, as well as the internal jugular vein exiting through here as well. It's roughly bean-shaped and sits on the margin between the occipital and the temporal bones. So the 3 nerves that are passing through are the glossopharyngeal minus the lesser petrosal. And the way that what the glossopharyngeal nerve supplies is taste to the posterior 1/3 of the tongue, motor innervation to basically all the glands inside the mouth that aren't the parotid gland, as well as sensory innervation to the external portions of the external ear and portions of the pharynx, and motor innervation to the stylopharyngeus muscle, which is a muscle that is critical to both swallowing and talking because it helps to raise the pharynx. Additionally, we have the vagus nerve, which is the overachieving nerve that we all kind of hate. So it's true. The vagus nerve comes through and provides a ton of visceral sensation and motor sensation for a ton of structures, literally from your dura mater to your guts. It goes all over the place, and my drawing actually cuts off because I needed it to fit on the page comfortably. But critically for this lecture is that it provides sensory and motor, it provides sensory information innervation to the dura mater and sensory and motor innervation to the soft palate, pharynx, larynx, and esophagus. All of these have critical roles in things like swallowing and speaking. Additionally, there's innervation in the trachea, the bronchi, the heart, the GI tract. It does it all. In addition to these two incredibly complex cranial nerves, we also have the accessory nerve, which I actually didn't draw because it gets cut off in this figure. It provides motor innervation to two muscle groups, the sternocleidomastoid and the trapezius muscles. And then in addition to these three nerves passing through the jugular foramen, you also have the internal jugular vein, which drains blood out of the brain and then drains into the common jugular inferior to it. Last but not least, we have the hypoglossal canal. Now, the hypoglossal canal actually is it's also called the hypoglossal foramen. It provides the passage for the hypoglossal nerves to exit the brain case and go to innervate the extrinsic and intrinsic muscles of the tongue. So now we've looked at all this broad anatomical relationships between all the different cranial nerves and how they actually exit out of the skull. Let's get back to our patient. So what cranial nerves could be potentially experiencing dysfunction here? So for the occipital headaches, that would potentially be the vagus nerve because it has a meningeal branch which innervates the posterior dura mater. That would fit perfectly for occipital headaches, especially chronic ones. Difficulty talking, that could be a problem with the larynx. It could be a problem with the pharynx. It could be a problem with the tongue, actually, but there was no abnormal tongue findings from the physical examination. So I think we can rule out the hypoglossal nerves. But the glossopharyngeal and the vagus nerves innervate the pharynx and larynx respectively. The vagus also innervates the pharynx, both of which provide critical nerve functionality to speaking. The same story actually happens with swallowing. The silopharyngeus muscle is a critical part of swallowing, and vagus actually provides the esophageal innervation to be able to initiate to actually continue the swallowing event beyond the pharynx. Now, difficulty turning her head is indicative of a problem with the sternocleidomastoid muscles. Now, there's one nerve that innervates that, and that is the accessory nerve. Hopefully, everyone was able to see that one coming. And then last but not least, there's the deviated uvula. Now, deviated uvulas occur when the soft palate, the palatal arches droop. So if my fingers are a uvula and my hands and arms are the palatal arches, if my palatal arch droops, it causes the uvula to deviate. And the way that it works is that the uvula will then point to the unaffected side. And this is an issue of the vagus nerve because the vagus nerve innervates the soft palate. So the question is, do these nerves have a shared location? Because then we could just know where to look. And they do. All these nerves exit through the jugular foramen. Remember, nerves that run together get injured together. So what you can do is you can now go in and try and image that area to try and investigate, see if you have a lesion. Now, this is just an example, and it kind of captures what you can have, where one side you can see the jugular foramen, and on the left side you can't because there's a giant mass that's obstructing the jugular foramen. So what our patient is experiencing is something called jugular foramen syndrome. This is the paresis of the cranial nerves 9, 10, 11, and sometimes 12. This can be caused by schwannomas, which are tumors of Schwann cells, which are found in myelinated nerves, which basically all cranial nerves are. You can also have meningiomas, which are tumors of the meninges, which, as I mentioned earlier, since the meninges do connect to the foramina, it is a prime breeding ground for a very quick foramen effect if there is a meningioma growing by a foramen. Additionally, you can have occipital bone fractures, surgical complications. This is typically from a vascular approach within the internal jugular vein, and just good old-fashioned trauma. Additionally, here I have a fascinating paper about schwannoma health outcomes based on demographics. But hopefully, given all of this information and run through one specific case example, you'll have the tools necessary to be able to assess anatomical relationships and use them to be able to diagnose patient problems in class later. So I will see you then.